I'm sure I'm similar to many other clinical academics that a lot of the research I've done has come from questions that have been raised in my mind because of things I see in clinic. And 100% that, a bit like you talk about the circle, you see some data, you see something in clinic, you do the research to find the answer for it, and then you bring it back into the clinic. So there's a circle going on there. To me, those two aspects are completely integrated, and a big part of responsibility of clinical academic is conveying those research findings in really clear, understandable ways to our colleague healthcare professionals and also the people that I think the role of education is changing. I think what it's doing is it's bringing up the baseline. So when we didn't have CGM 10 years ago, we were using finger pricks and injection. And the people who understood it, who worked hard, were always still doing perfectly well. But the people who struggle with it because of psychology, emotion, time, other responsibilities, financial, geographical, lots of things happen in people's life, right? The bottom was much lower. As soon as we gave everyone CGM, that bottom came up. For example, and I think we sometimes overestimated the value of education. I'm not underestimating.
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights. Welcome everybody to Global Diabetes Insights. I'm Kona, and we have here with us today Professor Pratik. I tend to say Professor Patrick.
I know a lot of people get that.
Yeah, the change in the letter is so confusing. So we want to thank you for being here with us today. If you would like to introduce yourself.
Yes, I'm Professor Pratik Choudhary. I'm a professor of diabetes here at the University of Leicester, and I've got an interest in type 1 diabetes, technology, and hypoglycemia.
That's nice. Medicine is broad. There are so many things you could specialize. Even diabetes is broad. What made you decide to specialize in type 1 diabetes? Why type 1 diabetes?
I think I initially chose diabetes. It attracted me because it was this mixture of numbers, which I like, but also people. And what I liked the idea of diabetes was that you form a relationship with people over time, and not the kind of see someone do something and go. So I think I liked that sort of long-term relationship with people. And actually coming from India, where type 2 diabetes is a big problem, I thought when I was starting out that I'd do something around type 2 diabetes. But I guess, some of it is luck, and as many people, the opportunity came up with a project that was type 1. I ended up working with two of the big names, I think, in type 1 diabetes, Professor Simon Heller in Sheffield. I did my initial MD thesis with him. And then I worked with Professor Stephanie Emile, and both of those are, big names, big pillars who've done so much in type 1 diabetes. It was inevitable I ended up being attracted there.
I personally believe that there are so many differences between type 1 and type 2 diabetes patients. Do you see that as you have chosen to specialize in type 1 diabetes?
I think there are. I think they're very clear differences. I think in my head, one of the biggest differences is that people living with type 1 diabetes have to be more active, more involved in their condition day on day. I think a lot of people with type 2 diabetes can afford to be maybe a little bit more passive. The disease happens to them, and over time, take a tablet and I can get on with life, right? Whereas type 1, you have to think about it all the time. I think the mental health aspects are very different. But interestingly, I think I found they were very disparate, and I used to kind of make sure that everyone said type 1 or type 2. You couldn't say IDDM or NIDDM. But actually, in the last couple of years, I think things are moving a bit closer together again, particularly with insulin diabetes, particularly with a lot of technologies in type 1 moving into type 2, and a lot of disease-modifying drugs from type 2 moving across into type 1. So there's an interesting dynamic in the next 5 years.
You mentioned it, that your work focalizes in hypoglycemia, and especially unaware hypoglycemia, and also was the major project you presented in ATP. So do you want to take us through it? Why hypoglycemia? Why unaware hypoglycemia? And what's your project, HypoMETRICS?
So I'll break that up into three, because they're probably three different stories, actually. So why hypoglycemia? That's because, I was a junior doctor working on the wards in Sheffield. And my boss, the consultant of the ward, Professor Simon Heller, came up and said, "Hey, are you interested in research? I've got some money to do this research project." And it was money from the Department of Transport to use continuous glucose monitoring in 2000, right? Just a year after it was introduced, because they wanted to see whether if you're type 2 and using insulin, in those days in the UK, you could not drive a lorry. So you had lots of people who heavy goods drivers spending a lot of sedentary time getting type 2 diabetes, but if they took insulin, they would lose their job. And so the question was, are they at a high hypoglycemia risk? So back in early 2000, 2002, I think, project started and recruited across 6 sites, 600 people, and used CGM to measure hypoglycemia. And actually, as a result of that, ultimately, now people with insulin-treated diabetes are allowed to drive lorries because we found the risk was manageable. That's why hypoglycemia is just because that was a project that the boss gave me, and I started using CGM.
So it was by an accident. It's not a spiritual story.
Yeah, just kind of serendipity. That's why technology and CGM and hypoglycemia became the thing. And then I moved to King's in London, and I worked with Professor Stephanie Emile. And she was a collaborator in that first project anyway. And her interest has been in why people lose awareness of hypoglycemia and how you can restore it. So I've ended up then spending the next 10 or 15 years doing research in that field. I did a lot of work. We made people hypo down to a glucose of 2.5 or 45 milligram per deciliter in the MRI scanner, comparing non-diabetic people with good warning signs and people with no warning signs, trying to understand what's different in the brain and also what's outside of the scanner, what's different in their behavior. And then looking at different ways to restore awareness, including education, including technology with pumps and sensors, and including psychology. So I was involved in developing a project called HeartDoc. And then, of course, when I was at King's, I also ran the islet transplant program, which is for people with problematic hypos. So for the last 15 years, 60% of my patients were patients who had impaired awareness of hypos or recurrent 50 glucagon in the last year, people with horrible problems with hypoglycemia. So helping those people, and that my clinical practice matched my research practice. That's why hypoglycemia and technology,
It's interesting because usually people involved in type 1 diabetes, healthcare professionals, are talking about the fear of hypoglycemia. And you went to another view of hypoglycemia, which is unaware hypoglycemia. If you had to choose between those two, which one would you tell is more dangerous, unaware hypoglycemia or the fear of hypoglycemia in diabetes treatment?
They're both really important questions, right? If I can give a data-driven answer as a scientist or a researcher, I will say there's some work that needs redoing, I think. There's a project by a lady called Teresa Anderbro in Karolinska in Sweden. What she did was she mapped fear of hypo against risk of hypo. And she found that most people had a low risk and a low fear, right? But there were some people, about 25%, who had a low risk but a high fear, and they ran really high. And then there were some people who had a high risk and a high fear, and that was fine as well. And there's these other people who have a high risk but low fear. So when you say what's worse, actually both arms are equally problematic, except one, people who run high because of extreme fear. And actually the work I've done with hypos helps me address that part of the story as well. Although I've not done any research, but in clinical practice, we address that. But the other group, the people we end up seeing in everybody's clinic, there are those 5 or 10 people who have recurrent severe hypos who are very focused. And actually the technology, CGM, is making that a bit worse, where people are seeing the lines, the CGM traces, and wanting to keep it flat and over-injecting and keeping glucose really low. We know people die from hypoglycemia as well, although thankfully very rarely. But I just don't like to pick between two challenges. It's just, I've ended up being involved with this end of the spectrum.
You mentioned CGMs. My personal opinion is that CGMs were introduced over a night, if we can say. We end up using CGMs and not being psychologically trained to have so many data for our numbers and what to do with them. For example, when I first wore my CGM, I saw the arrow going up. I always overcorrected, and then I ended up having a really low and then a really high. So what's your opinion on that, and what advice can you give to people who are starting to use CGMs and how to use that over information we're exposed to?
This is the part where I'm trying to be very clear. There's half of me that's a scientist, a researcher, and there's a half of me that's a clinician.
Yeah.
Right. And so this question, I'm going to answer with my clinician hat on without much evidence, the things that I say in clinic, but they are informed by what I've learned in research. And we'll come to hypometrics if we can, because that informs a little bit more about the fear of hypoglycemia. What I found, exactly like you, let me break things up. So there's people who are low viewers, who don't look at the CGM a lot, they wear it, and they're in a different level of diabetes distress. They're generally running high. And the reason they don't want to see the numbers because they don't want to see a number that says that you're not doing well. If I'm going to fail an exam, I'm not going to run to school to open their result card. And the person who runs high knows the reason they're running high is because they didn't cover that meal, they underdosed. They know what behavior, action they did not do. And then why would you scan and check to confirm your inability?
Your failure.
Yeah. So in that scenario, asking that person to check more, you have to be very careful. So one of the things that we do very carefully, I was taught a long time ago, was I say, okay, in my clinic, we never ever use the word test. Now, I don't know what the language equivalent is in Greece or Italy or Spain, but in England, it used to be test your sugar. Yeah, I don't know if in your language, but so test is a pass or fail. It tells you, so my clinic's things, look, the reason why you need to measure your glucose is to decide what action you need to do in the next 3 to 4 hours and make sure that action is correct. That action might be do nothing, might be take carbs, might be take some insulin. There's 3 actions that you can do, or might be I need to check again, measure again in a certain time frame. So there's 4 decisions you make at any given time. To make the best decision, you need to measure your glucose. It's not a test. Am I good or am I bad? There's no value judgment on that number. It's just a number to decide what do I do in the next 4 hours. Okay, that's the first thing. Then you've got the people who are measuring appropriately. The average, I think the right sweet spot is around about 8 to 12 a day. And then you've got people who are scanning and viewing more. That to me is a marker of high degree of anxiety. It's a marker of high degree of engagement with the diabetes as well, right? Because you want to know what's going on, but it's anxiety. And how do you pull that back? I say you want to do actionable measurements, right? Same with alarms. The alarms have to be actionable. Your views have to be actionable. So when do you need to action? So what I think is, okay, the most important time where you need to measure, know what your glucose is pre-meal. Yeah. So we come up with a little slogan, which is measure, inject, eat, forget, repeat. Because once you've measured, injected, and eaten, that order is important. Whatever the companies say, you can't inject post-meal. You got to inject pre-meal. Once that's done, then you're going to rise. There is no value in looking at your glucose in the 90 minutes post-meal, because the only action we'll do is you'll see the rise, you'll panic, you'll want to do something. If you take some insulin, you're going to have to take carb extra and you're going to have a hyper, right? Okay, you can have a look at if your alarm goes off because you're 300 or 15 millimoles, right? Generally speaking, it'll go up and it'll come down. The time that when you're going to go most value for work is 2 hours post-meal. And that's a safety check. It's a safety check because even if you've got your dose correct, something might have happened those 2 hours. Maybe you're a bit more active, something happened. Maybe you injected close to a capillary, the insulin worked better. If you're going to go low, most lows happen at 2.5 to 3 hours. So if you check at 2 hours and you're already below 100 and dropping, below 6 millimoles per liter and dropping, then you can have 4 to 8 grams of carbohydrate, smoothen the trace out and prevent the hypo that would have happened had you not checked. If you're between 6 and 12, which are 110 and 200 maybe, then actually you're going to land in range. No action really required. And if you're high, because maybe you had fat, protein, stress, sedentary behavior, then you can, after 2 hours, then you can use a bonus advisor. You can consider what correction makes. So action times are pre-meal and 2 hour post, and then pre-driving, pre-exercise, and a couple of others. So when you add that up, it's about every couple of hours. So my pitch is, okay, how can you be efficient in the work you're doing and not just kind of keep looking at it and then bounce from one side to this? That's the practical advice I give.
Yeah, that's very important because most people with diabetes tend to expose themselves in those information and they don't know what to do with these numbers. It's like weighing yourself every day, 10 times a day. I mean, your kilos are going to go up or down if you drank water or went to the toilet, I don't know. But it doesn't really say something to you. There is appropriate time to check and take action. And then if you're strong enough or educated enough, you can see an alarming number and have the courage to not do nothing because you know how your insulin is going to act.
And the other thing we say is that actually, you know what, in this exam, diabetes, the pass mark is 70%. Yeah. That means your allowance to be more than 180, 10 millimoles per liter is 30%. And 30% of the day is about 8 hours. So if you see a number that's high that you've taken some insulin for, it's just part of your allowance. Some days you're going to use your allowance, some days you're not. And actually, if you look at the data, in terms of complication risk, there is no measurable benefit from being at 85 or 90 compared to 70, 75. Yeah. So the things that we have to say with the data. So just as a note, in the UK, I used to run chair of an organization called Diabetes Technology Network. And if you Google DTN, Diabetes Technology Network Education, there's a whole bunch of videos that include pumps, sensors, CGM, pregnancy, and hybrid closed loops that just kind of give some information from a variety of UK experts. That's all in English and freely accessible to anyone. And we also did the same. We're going to do some more on the EASD e-learning as well to put some of those in that format as well.
Hopefully we will get the link in our description. You'll send it to us. I think I have read some research saying that people living with type 1 diabetes and especially girls are more likely to develop an eating disorder and especially obesity. And I know that you were part of a panel about obesity and type 1 diabetes. So I would like you to give us some information, some advice, piece of knowledge about this.
I was involved in the ATD organizing committee and I put that panel together because I wanted to learn about this topic, not because I know much about it. 100. Right.
Okay. That's honest.
Yeah. We're seeing that people with type 1 diabetes, as the background population is getting heavier, people with type 1 diabetes are also getting heavier. It's causing some diagnostic challenges. Because in the UK, we found that 10% of people, a colleague of mine in Scotland called Fraser Gibb, Edinburgh, he surveyed a C-peptide and everybody labeled type 1 diabetes in his clinic and found 10% were not type 1.
Okay.
Some of them were early onset type 2. Many of the people labeled type 2 were, because they're overweight, were actually type 1. Right? So there's one point there about obesity type 1, that is, get the diagnosis right. C-peptide is a cheap test, less than 10 euros.
Yeah.
That maybe last month, I changed someone who'd been diagnosed at the age of 32 as type 1 and he was type 2. And it goes either way. So that's the first thing to say. Second thing to say is, yes, we know that people with type 1 diabetes exercise less than the background population, possibly because of linked to fear of hypoglycemia. Information about how to exercise more safely is important, but actually to exercise safely in type 1, you have to take some carbs. So you have to think carefully about exercise anyway is for cardiovascular fitness, and that's why it should be done. Right? Because with type 1 diabetes, there is, even with perfect glucose control, a slight excess cardiovascular risk. And that's why we should be more aggressive with statins, and we should be more promoting of exercise that reduces that cardiovascular risk. My opinion is that a lot of people get mixed up with the relationship between weight and type 2 diabetes, which is a very causal relationship, and weight and type 1 diabetes. Right? In type 1 diabetes, you have a very clear metric of insulin resistance because you have their total daily dose. And the average total daily dose in type 1 diabetes is about 0.5, 0.6 units per kilogram. So I've seen obese people, 100 kilos, on 0.5 units per kilogram. So to my mind, they're not insulin resistant. Right? And I've seen people who are not that overweight, but they're on 0.8, 0.9 units per kilogram. To my mind, they're insulin resistant. And it's insulin resistant that leads to the cardiovascular risk and things, right? If you unpick it, there's a diagnostic piece, there's the cardiovascular risk piece, and then there's the social issue of weight and what you're doing. And then how do we use weight lowering interventions ranging from very low calorie diet to intermediate time restricted eating or intermittent fasting to pharmacotherapy to exercise in a safe way in type 1 diabetes. There are 4 bits there. And actually what the symposium at the ATTD showed was that there was pretty good evidence actually for safety for GLP-1 therapies in obese type 1 diabetes. They seem to be observational data now, not an RCT, but observational data showing benefit, or similar benefits as in type 2.
We've mentioned it that as technology progresses, we can benefit by having a better view of our diabetes, and also where we can focus on becoming better. For example, with CGM, we have a full view of our values, of our days, of our months. Things are getting faster evolving than some years ago with hybrid closed loops and stuff. What's the next step? What the future can bring to us?
I'm going to actually take a step back. There's something that I want to talk about that we missed out, which is relevant to that question. That is, with now, in the UK, we have universal coverage of CGM for type 1 diabetes. And in many European countries now, that's standard of care. I want to make a point about that means that healthcare professionals have to really change the way they interact and talk with people, right? And so I think a big push in the next few years is change that. There's a greater awareness of mental health and diabetes and the burden it places on people. And I think I've just spent 2 days deciding on a research project on how do you reduce diabetes that we're going to implement some tools that will help clinicians work better, talking to people and identifying technology and the data to keep out of stress. One of that is hypoglycemia. And I just want to make a point about the HypoMETRICS project that we presented at ATTD, and we'll present some more data at future conferences. One of it's about how we define and talk about hypoglycemia. So what we found was in our study, we had 10 weeks of data where they wore a blinded CGM, and every day they reported on a bespoke app. They would report every morning how you're feeling, what's your energy levels, what's your different domains, 9 domains of life, how you're feeling, how sharp you're feeling, how energetic you're feeling. And then also they reported for 10 weeks, this is 250 type 1s and 350 type 2s, so 600 patients for 10 weeks. Every single hypo they could feel. If they ever had a hypo, once they'd recovered, they say, I had a hypo, I recognize it because my finger pricked it, or maybe we get a blinded sensor, but some of them were wearing their own sensor as well, right? Depending on what they were. We recorded how they found the sensor, what symptoms they had. And what we found was that people only identified about 35 to 40% of sensor detected hypoglycemia. And that is even at a glucose of 70 or 3.9, but also at a glucose of 3 or 54. Even at 3, people who are said to be aware only pick up 30% hypo. Now, actually, that's not surprising to me. Any of us who don't have diabetes and have worn sensors know that our sensors beep overnight and we have low readings sometimes in the day as well. So it's physiological to have a glucose reading around about 2.6, 2.7 if you've been hungry, if you've been active a while. There's a paper by Viral Shah showing that happens in about 30% of non-diabetic people. This is not hugely pathological, and it's not surprising that some people with type 1 diabetes, if I'm focusing on something else, my attention is on something else, I don't recognize my hypo. So the first thing to say is that does not mean they are unaware. That happens in aware people. The unawares only, so the aware people recognize 40% of their hypos, and the unawares recognize 20%. Okay, that's the first important fact, because I've had some people refer to me saying this person is unaware because they did not detect their hypos, but it is not normal to detect every single time your glucose goes below 70 or 3.9.
Excuse me for interrupting you. Also, sometimes I see, for example, a hypo like 7 or 68, and then I start to feel like I'm low just because I saw the numbers. It's clear
Correct.
Psychology.
Anxiety, because it's impossible to differentiate the symptoms of hypoglycemia, tremor, shake, anxiety from the anxiety of, oh, I might be going low, something bad might happen, right? And that's maybe part of the reason why 50% of the time people said, oh, I've got some symptoms, I'm probably low now, and they treated it, the sensor was not low. So there is a disconnect between sensor-detected hypoglycemia, biochemical hypoglycemia, and patient-reported hypoglycemia, the patient experience. We were taught in medical school, I was taught when I was doing research in hypoglycemia, that there's this linear fashion. Your glucose drops down, and when you get to a certain level, you get adrenaline, you get symptoms, and then you go below and you get cognitive dysfunction. I think our data says that's not quite true. We don't know why you're aware of some events and not the others. It doesn't depend on rate of fall. It doesn't depend on time of day. It's a bit worse at night than in day, which we knew from a long time ago. So the first big message out to people is that seeing a little bit of red on your Libre trace doesn't mean it's a disaster. And actually, what the most interesting thing was, we looked at nights. Every morning, the patient reported how they're feeling, right? If they'd had a hypo that they were aware of, that they reported, yeah, I had symptoms, or my machine beeped and told me I was low, there was a clear reduction in quality of life the next day, which is understandable. If you're anyone who's got a young child will know, if your sleep is broken at night, you feel crap the next day. I think that's not about hypoglycemia, that's just about broken sleep. But if the glucose was low and the person did not know about it, there was no measurable reduction in quality of life. And the place where you place your alarms, if you were to put your alarm at 5 or 90 because you're scared of hypos, you get about 10 events a week. If you put your alarm at 4 or 80, that will be about 5 events per week. If you put your alarm at 3, which is the dangerous ones, 55, you get about 2 events per week. So when people are worried about hypos, they put their alarms at, what you're doing is you're increasing the negative impact of hypoglycemia in your life with no measurable benefit. The alarm should be to protect you from falling off. And that is, we know glucose below 3 is associated with cardiac, neurological, inflammatory effects. So there's no denying that part of the story, level 2 hypoglycemia. But with this hypoglycemia definition, I'm increasingly unclear about what level 1 hypoglycemia between 50 and 7, if it has any real biological impact. Its only impact is negative psychological fear. And, I had a patient with me the other week and she was saying, Doc, I'm having lots of hypos on hybrid closed loop. It's not working. And I looked at the data and there was 0% time below range. So the nurse had put the alarm, because 4 is hypoglycemia, put the alarm at 4.5. And she was getting all these alarms at 4.5. And every time the alarm goes off, what she taught, hypoglycemia can cause you to lose consciousness and could cause you to die. So every time this alarm goes off, the whole family runs with some glucose and drink cans of Coke and orange juice. And she thinks every time the alarm goes off, I'm going to die. Yeah. It's how we communicate risk and how we communicate the issues, and the fact that actually in this study, there were 20,000 events of level 2 hypoglycemia that the patient didn't feel, that had 0 negative impact on the people. So within that, there are some events that go really low and cause severe hypos, but they're very rare. Even the reviewers said, hey, you had so many events of below 40, but there were no severe hypos. Well, that's exactly the message I want to give out. Actually, the body's incredibly resilient. We need to balance that fear of hypoglycemia a bit better with the risk. Yeah. And the risk is moderated by whether you've got awareness or not, whether you've got technology or not.
Yeah, I think it all has to do with very well-educated health professionals and then very well-educated by patients, because I think diabetes is a circle of getting data and making decisions according to the data. So it's an endless circle, but if you aren't well trained, you're going to take under consideration more your psychology than what you really need to do.
Completely agree. Very well said.
Yeah, thank you. The other thing that I would like to ask you, personally, I'm a type 1 diabetic during my residency, and I try to balance how I experience diabetes with how I advise someone who has diabetes. Of course, my personal opinions or my experience driven by my emotions, this is a fact, which is not. It's something that has to do with me. I would like to ask, how do you balance the research part of you and the clinician part of you?
I'm sure I'm similar to many other clinical academics, that a lot of the research I've done has come from questions that have been raised in my mind because of things I see in clinic. And 100%, that a bit like you talk about the circle, you see some data, You see something in clinic, you do the research to find the answer for it, and then you bring it back into the clinic. So there's a circle going on there. To me, those two aspects are completely integrated, and a big part of responsibility of clinical academic is conveying those research findings in really clear, understandable ways to our colleague healthcare professionals and also the people that we support.
Before we talked about technologies, I would like your opinion, because we see that technologies are continuously evolving, but are the education patients increasing too? I may be a very well-trained diabetic using just a CGM with pens, but very well-trained, so I may have better diabetes management than someone who is uneducated but has a hybrid closed loop.
I think the role of education is changing. I think what it's doing is it's bringing up the baseline.
Okay.
So when we didn't have CGM 10 years ago, we were using finger pricks and injection. And the people who understood it, who worked hard, were always still doing perfectly well. But the people who struggle with it because of psychology, emotion, time, other responsibilities, financial, geographical, lots of things happen in people's life, right? The bottom was much lower. As soon as we gave everyone CGM, that bottom came up. For example, and I think we sometimes overestimated the value of education. I'm not underestimating it, but maybe because a colleague of mine, Fraser Gibb, in Edinburgh, they had access to CGM. He had 1,000 people in his clinic. And in 4 weeks, on a Sunday, he rented the medical college lecture theatre and he started 250 people every week. In 4 weeks, the whole clinic was on CGM. Other people, we were at the moment, it's very complicated, so much data, let's bring them in small groups of 6 to 8 and teach them about sensor lag and when to scan, all these things, right? So in 4 weeks, we would have started 100 people and he started 1,000 people. By 3 months, his clinic average A1C dropped by 0.5%, and the proportion of people with an A1C more than 10% halved. What does that tell you? It tells you that the data pulled up the bottom end much faster than education could have done, right? And education is a barrier because although education is great, not everyone can access it. And it's no point having a super education program that no one can get. But the people who are educated go a bit higher than those who are not. And same thing with closed loop now. That bottom is pulled even higher. So people who don't get it find it hard to deal with. And now instead of running, so without CGM, they would run at 10%. With CGM, they run at 9%. With hybrid closed loop, they run at 8%. So people with educated are the ones who are getting down, but it's reduced the gap tremendously. And people who are well educated with HCL still do better. The expert patient will still outperform a machine. If you would have to choose 3 things that need to be prioritized in diabetes care regarding healthcare professionals, what would that be? Regarding healthcare professionals, I think it's psychological awareness and skills in healthcare professionals looking after people with diabetes. I think there's a big gap. I think people are comfortable. It's a different model of care. It's not an endocrinology model of care where, I've seen a number, I just need to change that dose of thyroxine or investigate things that are completely human. So I think that's an area that is growing increasingly relevant, could be done better. I think the second thing is a bit more of how we arrange care. I disagree with the model of care that is everyone should be seen every 3 months. No, it should be demand-based. There are people who I can remotely log into their data and have a quick look at, and they're fine to be seen once a year or maybe even longer. And there's people who should be seen every 2 weeks when they're really struggling with things, and how we see them remotely and who sees them. I think a bit more personalization in how healthcare delivery interacts with people. I think those are 2 things, and healthcare professionals and just knowledge and awareness. And the technology has gone much faster and the healthcare teams are still catching up. We're going to roll out hybrid closed loop to almost everybody in the UK with an HbA1c more than 7.5% is eligible. So that might be about 250,000 people. And our capacity, my hospital used to start 50 people on a pump or 60 people a year. We've gone to doing 40 a month. But that's taken a lot of. You mentioned psychology. Recently, seen groups of people living with diabetes taking part of great diabetes conferences and symposiums. How important do you find diabetes becoming a patient-led disease? I've been to doctor appointments where I express the things that you're telling me do not accord with my lifestyle. And there is such a resistance to understand my point of view as a patient. How important do you think this new movement led by people living with the disease is? I think what you've just explained highlights the need for psychological awareness amongst healthcare professionals. But I think the patient movement is doing that. The presence of people lived expertise. We're very careful about what words we use, and they're not there in the capacity as patients. They are experts by experience. And their expertise may be different to our expertise. We're just learning about how do you co-design or co-create treatment plans or healthcare. Things have moved from care being delivered to people without their involvement to a little bit of acknowledgement that we'll tell you what we're doing. And maybe if it's a research project, my funder might make me involve you to say, hey, we're doing this. Are you okay with this? And I was just at a meeting yesterday where actually very nicely the research team laid out there is that level of care where this is what's going to happen, right? And then the second group as well, this is what we're going to do. Are you happy with it? Do you want to change it? Or this is what we suggest. To now, with a lot of research in healthcare delivery, having experts by experience co-designing the pathway. And that movement gets voiced by those people turning up. But the people coming to conferences have another important message because they're taking the top end of research and democratizing it via social media out to the people who actually, why do I do my research? Why do I say this is what happens with hypoglycemia? Yes, I can tell the doctors, they can tell their patients, but actually if it goes straight to the people living with diabetes, it has bigger impact.
Yeah, and I also think it's important for healthcare professionals to manage their ego because, as you said, people living with the disease are expertise by experience. That doesn't mean that people who have studied don't know. They can accept modifications to what they're saying or proposing by the person who this information is addressed to.
Absolutely.
Yeah.
But it's changing dramatically. The mindset is changing and you're getting a new generation of clinicians who are far more aware of these issues. Quality, diversity, PPI, these are all now key issues that we can't do anything. The funders, the organizations are pushing that direction, but we need to move along with it.
I would like you to also give a piece of advice to a newly diagnosed diabetic who is now watching this podcast.
I think the main thing is it's going to be okay. It's going to be okay. What you might have read or heard or your emotional circle around you will say, this is not the disease it was 10 years ago. This is not the disease it was 20 years ago. It's certainly not the disease it was 40 years ago. I saw someone in clinic yesterday and she was diagnosed 15 years ago. And she said that when I was diagnosed, she was a doctor as well. She was a medical student when she was diagnosed and she went to the textbook and she read the line that your lifespan will be reduced by 15 years. That is simply not true today. And so it will be okay. The rates of life-changing complications we're seeing now are so low compared to, and we've got the technologies. We've got a holistic view, technology, psychology, education coming together. Get the right people that we need to change the healthcare system. But it's tough. There are things that you have to do that people without diabetes don't have to do. Your healthcare professional's job is to find a way to fit this condition around your lifestyle. But the main thing is it's going to be okay.
Thank you very much. For closing, I would like to thank you very much for dividing your time to our podcast. Maybe you'd like to share a coming project or something you're involved in currently and we're waiting information or some outcomes.
I think the next year or so, we've got lots of outcomes still coming from HypoMETRICS, which is our project where we looked at the association of hypoglycemia and its impact on people. So there's lots of analyses that we're doing. I'm involved in a large American NIH-funded project where my interest in impaired awareness. So we're looking to see whether hybrid closed loop can restore awareness in people who've lost their warnings, but we're also testing hybrid closed loop and some educational and some psychological interventions to see how these work together to get a pathway. If you've lost warning signs, if you're having lots of hypos, how can we work to bring that back? So that's a big part of what we're doing with, as I said, just doing this project to develop an intervention that can reduce diabetes distress for people who find it just a bit too much. Yeah, so those are probably the three main projects I'm involved in over the next few years.
Okay, once again, I would like to thank you for being here. I think that the fact that you blend your research knowledge with your experience as a clinician is so valuable to people living with the disease. Promoting this holistic approach is so key because people with diabetes are saying it, but seeing people who are actually healthcare professionals supporting it is so key and important for us. Yeah, I wish you a great day. And again, thank you very much.
Thank you. It was lovely speaking to you. Thank you.